which is on promotion of evidence-based medicine, controversies to consensus. Today's theme is menopause, and it is a brainchild of Durga Das sir, where we have initially 4, now we have 3 societies who are participating, sending their speakers. And of course, at the end of the webinar series, the best speaker will be awarded the prizes. And today we have great pleasure in having Ambuja ma'am. So with this, I will give it over to Durga Das sir to give the presidential address. Shall we do the lamp lighting, sir? And then, yeah.
First, Arun lamp lighting.
Arun lamp lighting.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
I request Durga Das sir to give the presidential address. Thank you, sir.
Good evening, friends. At the outset, I congratulate Dr. Srimati Raman for the wonderful work she is doing, of course, guided by none other than Dr. Jyotika Desai and Dr. Sundari. She always selects the best theme which is very relevant for the clinicians. Like today's theme, menopause. Every clinician should know the basics of it. She has selected such a good topic, and I'm happy to see the 3 very good speakers of today, Dr. Saubhagya Bhatt from Belgaum, Dr. Pandurangaya from Chikmagalur, and Dr. Sujata from Manipal. As the icing on the cake, today we have Dr. Ambuja Chornoor from Hyderabad. I'm happy that she is from Karnataka. Madam, Kasoga thanks you immensely for joining to the for today's event.
Thank you, sir.
Without any wasting any time, I say best wishes to all the 3 participants, and I request all the delegates to make the best use of these webinars, and from henceforth, please, more and more doctors, please log in and utilize this opportunity. Thank you.
Thank you, sir. So I will, we'll start the proceedings, sir. I will introduce the 3 judges. So it's a great pleasure to have Jyotika ma'am, of course, who's been the series judge, who's been the advisor. Madam is a great academician, great teacher. So she's a senior consultant in PR Desai Hospital, past president of PSOC, current advisor to Kasoga, and ma'am has got many achievements. And I'm sure everybody in Kasoga, everybody who's logged in today knows about ma'am. And of course, Dr. Sundari ma'am is also honorary professor now as SMS IMSR. So madam again is a great academician and a clinician. She is joining us even from US despite the time zone. So it's a great pleasure to have you ma'am with us. And we have an expert and series judge this time is Dr. Ambuja ma'am. Dr. Ambuja Chornoor is a retired professor and HOD from Osmania Medical College, Hyderabad. And I mean, no other than ma'am to be the expert in this theme on menopause, because madam is a past president of Indian Menopause Society. So it's a great pleasure to have you with us, ma'am. Ma'am?
It's enough.
Yes, ma'am. Yes, ma'am. Thank you, ma'am. And madam is been awarded the Best Teacher Award 2 consecutive years by Gandhi Medical College. So it's a great pleasure to have you with us, ma'am. And it's an honor. And now the 3 speakers who have been selected by the 3 societies. First is from Belgaum, Dr. Saubhagya Bhatt. She's currently consultant in Patet Fertility Research Center. Before that, she was working in Kasbekar Medgood Clinic. She has been the past president of Family Planning Association as well as the past president of Belgaum Society. We have Dr. Pandurangaya, who's the current secretary of Chikmagalur OPG Society. He's an associate professor in Chikmagalur Institute of Medical Sciences, and he's also a member of the PCPNTT, and he has been the chair and the organizing committee of AKCOG, and he's got lots of research articles to his credit. And then we have the final speaker, Dr. Sujata, who's Associate Professor from Kasturba Medical College, Mahe. And she has won the Young Talent Award back in 2013 in AKCOG conference. And she's also got lots of publications to her credit. So it's a great pleasure to have you all with us. And may I remind all the speakers, Sir is a stickler to time. So we want to also make sure that we start and finish on time. So 12 minutes for the speakers. I will give you a warning at the end of 11 minutes. 12 minutes for the talk, 3 minutes for the question and answers. Please don't exceed the time limit. And of course, after the end of the session, we also have the expert talk. And Amija ma'am is going to be speaking for about 20 minutes. And then we'll have an interaction for 10 minutes. We're hoping to finish on time. So with that, I would request the first speaker to share the slides, Dr. Saubhagya Bhatt, on non-hormonal management of menopausal symptoms.
Good
Jyotika
evening.
ma'am, you're there, ma'am.
Can you hear me?
Yes.
Okay.
Can she start, ma'am?
Yeah, we will.
I think they can, yeah.
Yeah.
I'm audible? Okay. Good evening, everybody. First of all, I thank the organizers for having given me an opportunity to share my thoughts on non-hormonal management of menopausal symptoms. So we know that more than 1/3 of the woman's life is spent in the postmenopausal period, and it is associated with few of the unpleasant symptoms which affect the quality of life. The symptoms vary, and there are more than 23 symptoms that can be enumerated. They can be vasomotor, somatic, genitourinary symptom of menopause, and neuropsychiatric symptoms. So they can manifest as irregular cycles in the beginning associated with hot flashes, night sweats, mood swings, insomnia, cognitive changes, etc. So, because of all these changes and physical change, especially with thinning of the hair and gaining weight and wrinkles coming on the face, the woman loses her self-esteem. So she will, more than this, because of the symptoms of hot flashes and insomnia, she comes to the doctor. Can we just tell her that this is because of a natural physiological process and you don't require any treatment? No, we need to treat her because the quality of life, both at home and mostly at the workplace, is also very, very important, and she has to be productive. So, just a few words about the VSM. The origin of hot flash is the thermoregulatory center of hypothalamus, which is innervated by kisspeptin, neurokinin B, and dysnorphin, also known as KNDY neurons. These are stimulated by neuropeptide neurokinin, which acts on the neurokinin 3 receptor. And this action is inhibited by the estrogen. And as the menopause approaches, the estrogen levels fall, the inhibitory effect is lost, which in turn causes hypertrophy of KNDY neurons and alters the activity of thermoregulatory center, and a small trigger can cause increase in temperature, hot flashes, and sweats. So, due to diverse symptoms, how do we manage them? We have to individualize the treatment because there could be associated comorbidities also at this stage. They can be having diabetes, hypertension, cardiovascular disease, or some of them may be undertaking medication for breast cancers. And so monitoring and management of the side effects is very important, and the treatment options that we can provide is lifestyle modification. For some people, hormonal therapy is ideal because when something is lost, you have to replace. So that is what is the hormone therapy does. But sometimes we cannot give the hormone therapy, or it is contraindicated, or patient doesn't want it. Then we have the non-hormonal medical interventions. So adopting a holistic approach using the above combination is the way to maximize the quality of life of the woman. So when we talk about the non-hormonal method, we have non-pharmacological and pharmacological. Whatever may be, the counseling is very important because they need to make a decision, because patient's decision is also equally important. So lifestyle modification, when we can consider, we have to talk about nutrition and balanced diet with adequate hydration. And whenever there is too much of heat, cooling methods like hand fan, drinking water, cold water can be done, and layered clothing, avoiding the triggers, or moving away from a stressful situation. And of course, yoga and physical exercise do help a lot. So now coming to the cognitive behavioral therapy, this is one of the therapies that can be followed. It is evidence-based psychological treatment that helps to alleviate the symptoms by changing the unhelpful thoughts and patterns and behaviors. So By doing this, it's a structural approach. Coping skills are improved and it does not eliminate the physical symptom. Only thing, the patient's coping up mechanism will improve and therefore she doesn't attach much importance to these symptoms and she can tolerate it. And next, coming to the nutrition. So nutrition is absolutely necessary because at this stage, she is in her 50s and early 60s. So what happens, there will be so many comorbidities. She may be diabetic, hypertensive, or her intake itself may be less, or she may be having some, at this stage, there is metabolism is reduced and some deficiencies are always there. So the balanced diet, whether vegetarian or non-vegetarian, has to be followed. The platter has to be colorful with cereals, nuts, legumes, fruits and vegetables of various colors and green leafy vegetables with the oil which is restricted has to be given. So for example, if I have to enumerate the calcium rich foods, they are best for the bone health and it is better to get the calcium from the food than from the synthetic materials or synthetic tablets. So the dairy products, soya milk, horse gram, these are the vegetarian sources of good amount of calcium. The whole grains, millets, ragi, jowar supply fibers and B vitamins. Fruits and vegetables are a source of vitamins as well as antioxidants, which is anti-inflammatory because inflammation itself is the one which starts many of the diseases. And phytoestrogens like soya, peanut, chickpea, cherries, they are important because they act like estrogen and probably help in reducing some of the symptoms. And quality protein of 2 grams per day is necessary for the muscle mass, bone strength, as well as muscle strength. So dairy products, meat, fish, and legumes give this, and meat should be always lean meat and not the red meat. And hydration of drinking about 2 to 3 liters of water and restricted to during the daytime is necessary for proper digestion. And the eating should be mindful. It should be physical eating and not the emotional eating because at this stage there is empty nest and therefore people just go on eating to control their emotions and that should be avoided. So intermittent fasting has to be followed and this helps as an anti-inflammatory and disciplined eating, maintaining the type and avoiding the night food is very important. And what is to be avoided? Deep fried snacks, high sugary food, ultra processed food, carbonated beverages, as well as high caffeine food. Carbonated beverages like Coca-Cola, they leach the calcium from the bone and they worsen the situation. So it's a big no. And there is a list of food items or the fruits or vegetables that can be included in the diet and they are specific to certain kinds of, symptoms. For example, for hot flashes, we can include blueberries, then cauliflower, as well as beetroot, and palpitations, we can give tofu, edamame, so on and so forth. Due to the paucity of time, I cannot go through the entire list. So we have to be aware and then use it in the diet. And next coming, after eating, what should we do? We cannot sit and lead a sedentary life that is going to worsen the situation. So yoga is a very traditional method of exercise that has been followed from time immemorial. So the yoga differs from that practice during the adolescents or the young adults. It is restorative yoga and supportive yoga because at this stage the balance is a problem. So it requires more number of duration because it is restorative, which helps to relax the nervous system. And the practice includes a group of psychophysical techniques, and it is effective in reducing most of the symptoms and it improves the sleep quality and it is safe and low cost and it has been scientifically proved also. And this is very interesting to know that there are 8 specific yogas which are supposed to help during the menopausal stage. And this has come in a Western article. So it is very interesting that even the Westerners are following the yoga as a lifestyle modification. And now, how does the yoga help? The combination of physical posture and meditation as well as breathing, they all work together for a comprehensive benefit by stimulating the vagus or the parasympathetic. So it positively influences the autonomic system, shifting the balance from sympathetic to parasympathetic, thereby fostering the feelings of safety, calmness, and well-being. And baroreflex sensitivity regulates the BP and heart rate. So it is definitely an evidence-based intervention that alleviates the symptoms and improves the quality of life. Next, here I just want to talk about the respiratory health, especially in the old age. Respiratory health is a big problem. People can have, they can community pneumonia, so on and so forth. When the deep breath is taken, the vagus passes through the diaphragm and this stimulates, that is the parasympathetic, vagus has a parasympathetic activity and thereby the oxygen saturation increases and the entire benefit is through this. So deep breathing helps a lot. And now coming to the exercise. As yoga, exercise also has all the positive effects, but on the VSM, there is controversial evidence. So exercise has to be regular. Weight-bearing activities like walking, running, dancing help in reducing the hot flashes and it improves the heat dissipation. It stabilizes the autonomic function and enhances the vascular adaptation and it is an endorphin booster. And any exercise should be of moderate intensity, whether aerobic or resistant training. And this moderate physical activity has to start from the beginning, that is from early 30s, 40s, so that they are strong at 60. It has to be an accrued physical fitness. So one cannot start once she hits the menopause. So the slogan fit at 40, strong at 60, independent at 80 holds good as far as this is concerned. So long-term physical activity reduces adiposity as well, and it in fact in turn influences the estrogen metabolism and thus reduces the VSM. But however, vigorous exercise is a big no because this may worsen the VSM and therefore benefits depend upon the basic endurance and fitness of the individual and that should be practiced from the beginning. Next, this is the article that is 2025 article which talks about the cumulative adult physical activity which reduces the menopausal symptoms. Next, coming to the pharmacological methods, we have the antidepressants and its activity of reducing the VSM was accidental discovery. We call it serendipitous discovery. SSRIs and
1 minute more, madam. 1 minute more.
Okay, SSRIs and SNRI were the first drugs to be studied and we have a lot of randomized studies regarding this. The action is by increasing the level of serotonin and norepinephrine and it helps, it blocks the reabsorption from the brain cells and supplies it to the synaptic cell. It destabilizes the thermoregulatory zone and thus controls the temperature. And SSRIs like paroxetine, escitalopram are preferred compared to SNRIs, which have more side effects. So this is a list of antidepressants like desvenlafaxine, which are SNRIs. Though the symptom is reduced with this, they have the adverse effect of increasing the hypertension. So paroxetine and citalopram are preferred. Then we do use gabapentin and pregabalin. They are anti-seizure drugs and the side effect is drowsiness. So fezolinetant is the new drug. It is a neurokinin blocker and it increases the liver enzymes transiently. So it should not be given when there is hepatic failure. So the phytoestrogen, just one slide. The phytoestrogens are from soya and they have the action on the estrogen receptor and they are supposed to be useful in vasomotor symptoms, but there are no scientific evidence. Same with black cohosh. And finally, moisturizers and lubricants are the ones which are used for vaginal dryness. I won't be dealing with this due to paucity of time. And ultimately, the tender loving care by the family members is the one which is going to help them. And thank you for your patient hearing.
Questions, ma'am? Ma'am, Jyotika ma'am, you're muted. Ma'am, you're muted, ma'am. Jyotika ma'am.
Yeah, that was quite a good rendition, and I like the way you spoke with a lot of evidence about exercise and yoga. Though we could have done more about the pharmacological therapy too, non-hormonal, because that is what also helps to most of our patients. Yeah. Okay, my question to you now is, why do some women not respond to phytoestrogens?
Yeah, some women may not respond to phytoestrogen because it acts on two receptors, alpha receptors and beta receptors. It acts on, and maybe here in India we don't have any formulation which are standard, and we don't have any study to show that which is the highest level that should be given, and the metabolism probably absorption and metabolism may be hampered. I'm not very sure, but this is what I think it could be.
Saubhagya, the answer is that equal is produced in the gut, and this equal helps in the action of phytoestrogens. Now, there are some people who have equal, which are produced, some women do not have equal. So those women who do not have equal will not have any response to oral phytoestrogens.
Okay.
So now there is a tendency to, I mean, it's not there in our country, to give equal as a supplement to those, who do not have equal in their body. Okay. Now, is Sundari asking, or shall I ask for Sundari?
Ma'am, I think you can ask for.
Okay. The other question is, I mean, this is for Dr. Sundari. She cannot log in. So what about breast cancer survivors on tamoxifen with vasomotor symptoms? How will you manage them?
So fezolinetant can be given. That is a new drug. So it does not have any side effects. Like, we can't use paroxetine and other drugs because it reduces the quality because they all compete with the same cytochrome C450. So fezolinetant, which is a newer drug, can be given.
Not yet available in India. What is available in India?
Paroxetine?
No. Paroxetine cannot be given with
No, paroxetine cannot be given. Gabapentin and this one can be given, pregabalin.
Yeah, you can give venlafaxine, desvenlafaxine, and of course gabapentin, like how you said gabapentin. Thank you, Saubhagya.
Ma'am, we will stop here, ma'am. It's beyond 15 minutes, ma'am. And it was Ambuja, ma'am.
Saubhagya Bhatt you almost covered all the points. My question is, what
Ma'am.
is a non-hormonal method that is approved by NICE as first-line therapy? We all know estrogens is the first line, but what is the non-hormonal which is recognized by the NICE as first-line therapy?
I don't know about the NICE. I know about FDA, paroxetine, and this recent fezolinetant is the one which is FDA approved. And NICE approved.
Fezolinetant is not easily
Not
available.
available. Yeah.
It is the CBT.
Sorry?
CBT is the one which is approved by the NICE
CBT.
as the first-line management.
Oh, CBT, yeah.
Yeah.
Thank you. Thank you.
I was thinking of the pharmacological method. Okay,
Thank you, Dr.
No,
Saubhagya.
it's
But can you
good.
stop
You did
sharing?
all the, you touched all the topic.
Thank you, ma'am. Thank you.
Dr. Saubhagya, can you stop sharing?
Yeah.
Thank you. So next we have management of genital symptoms by Dr. Pandurangaya. I think your video was not there, Dr.
Can you make it a slideshow, Dr. Pandurangaya?
Yeah, we can see you. So slideshow. Perfect. Yeah. Can you start, ma'am?
Yeah.
Thank you. Yeah. We can't hear you.
Is he muted?
No, he's not muted, but I don't know whether it's audio.
Yeah, I think now we can.
Yeah. Yes, sir. Please go on. Hello?
Dr. Pandurangaya?
No, we can't hear you. Hello? No, we can't hear you.
Arun, find out what the issue is.
Yeah.
Okay.
Maybe if he's sorting it out, maybe we can have Dr. Sujata's presentation, ma'am, while we're waiting.
Yeah, he'll have to log out again.
Yeah.
Stop sharing. Dr. Pandurangaya?
Yeah, he's ending. Yeah. While he is sorting it out, can we request Arun, please check with them, no? Meanwhile, Dr. Sujata, are you able to, so that we can proceed with the next one. She's going to be speaking on prevention of osteoporosis. Dr. Sujata?
She was here till now. Sujata?
Yeah, she was. In fact, the video was also on. Maybe I will call her.
Unmute. Yeah, she's unmuted.
Sorry, ma'am. Yeah, I'm there.
Yeah, great. Can you?
Yeah, can I start sharing?
Yeah, if
ma'am?
you can. Yeah.
Okay. Yeah.
So you opened your PPT, right? So niche there's a share button. No, click on that and go to the share screen one. Yeah. Perfect. Go to the first slide.
Middle of this one it is coming, I think. Just a second. No?
Yeah, no problems. Yeah.
Okay.
Perfect. Slideshow.
Yes, sir. Okay. Are you able to see, ma'am, this one?
Yeah. Can you put on slideshow, Dr. Sujata?
Yeah, sure, ma'am.
Yeah, perfect.
Yes, ma'am.
Yeah, we can start.
Start now.
Okay. Good evening, everyone. I'll be talking on prevention of osteoporosis. Okay, osteoporosis is a major public health issue, especially in older age women. Globally, about 1 in 3 women more than 50 years experience this factors. Out of which 20% of these die within 1 year, and 50% of them never regain their functional independency. So, prevention is the better key for prevention of these morbidities. Osteoporosis is known as silent disease because the moment it presents, it usually patients will be already far advanced. And what are the characteristics of osteoporosis? Osteoporosis is characterized by compromised bone strength, alteration in the microarchitecture. You can see in this picture. Both leads to increased risk of fracture, especially in case with the trivial trauma also. So common sites are lumbar, thoracic spine, proximal femur, and distal radius. So the peak bone mass, you can see in this picture, the peak bone mass is attained, is the maximum amount of bone mass which is attained at around 20 to 30 years. And after 50 years, there is a decrease in the both cortical and trabecular bone loss. Fall in estrogen is a cause for this decrease in this bone mass. So prevention strategies, primary prevention is to build up the peak bone mass and maintain bone health. Secondary prevention is to reduce the bone loss, especially in peri and postmenopausal women. Whereas in tertiary, it is to prevent the fracture, especially in case of osteoporosis. The main goal is to maximize the peak bone mass and minimize the bone loss in perimenopausal, postmenopausal women. So peak bone mass, it is usually maximum bone mass is attained in the first 3 decades. Genetic factor is a major one. It predetermines the peak bone, but equally healthy lifestyle changes also can modify the peak bone mass. So you can see in this graph, suboptimal lifestyle practices, which is from the childhood itself, can reduce the peak bone mass, which increases the osteoporosis chances. That's why it was aptly told osteoporosis is a pediatric disease with geriatric consequences. So encourage healthy lifestyle practices, balanced diet, physical exercise early in starting from the childhood and adolescence is most important prevent factor. Okay, strategies for prevention of osteoporosis: diet, nutrition, regular exercises, lifestyle modification, prevention of fall, regular health checkups to screen for identify women at risk of osteoporosis, bone mineral density testing, and some of the medications to prevent or reduce osteoporosis. So diet and nutrition, role of calcium. As you know that calcium is most important for the bone growth and development, and also it is most important for other things. Assessing total calcium from the dietary sources is done basically by the chart assessment. Both dietary and non-dietary amount of calcium is assessed. The RDA for women more than 50 years is 1200 milligrams. And if this is not reached, the supplements can be considered. Vitamin D is important for calcium absorption and encourage adequate sunlight exposure. Okay, basically in vitamin D, and this cannot be reached since sunlight exposure doesn't reach vitamin D, so you need to supplement with dietary, and also sometimes supplementation is also required. RDA for vitamin D, especially in postmenopausal women, is 1,500 to 2,000. Upper limit is 4,000 international units. Both calcium and vitamin D supplementation is key to ensure to prevent bone loss. So other things such as restrict sodium intake, increase protein intake, especially in young adults, and omega fatty acids, antioxidants, and other nutrients play a role in bone health. So prevention of osteoporosis, regular exercises, it strengthens the muscle and bone by improving the posture and balance. So basically, weight-bearing exercises and resistance exercises need to be practiced from childhood. And in postmenopausal women, balance and flexible exercises also can place an important role in maintaining posture. Tai Chi, stretches after warm up, all these exercises can be planned. At least about 4 to 5 times per week, lasting for 30 to 40 minutes. These exercises should be done. Most important is be consistent. You should follow to improve the bone health. Severe osteoporosis, never do forward flexions, lifting heavy weights, side bendings, all those things that itself sometimes cause the tearing effect in the vertebra that can lead to fractures. So professional advice is mandatory in these groups. Other lifestyle modifications such as quit smoking, maintain health weight, and then risk alcohol, risk caffeine intake should be there, and falls that especially is a crucial factor which increases the risk of fractures, especially in older women. So avoid falls such as using of non-slippers, anti-skid floors, proper footwear, lightning, assessment of vision properly, all those things are important. So regular health checkups to screen and identify women at high risk of osteoporosis. So as by age, strongest factor, then history of factors, previous history of factors increases, and family history of fracture increases the risk of osteoporosis. Smoking, alcohol, and then dietary deficiencies already we have seen. So muscle weakness, cytopenia also increases the chances of fall. Comorbid conditions, look for secondary osteoporosis because of hormonal deficiencies, and there are list of medications that can cause bone mineral loss. Physical examination, height loss of more than 1.5 inches is an indication to obtain vertebral imaging. So mobility and malnutrition, especially that is loosening of the tool, also increases the chances of fracture. Okay. So the American Association of Endocrinology recommends oral examination to predict osteonecrosis of the jaw. This was the secondary process of osteoporosis, which can be detected by various investigation. Not all investigation is done in each and every case. You can screen by just clinical examination and physical examination feature. So drug-induced osteoporosis, here most we would like to concentrate more on these three drugs. So is medroxyprogesterone, aromatase inhibitor, GnRH analog. So aromatase inhibitor, GnRH analog, fracture risk is assessed by DEXA scan, whereas MPA, just monitoring of vitamin D and calcium levels is sufficient. So what do screening say? Targeted screening. So in menopause society says women above 40 years, you need to start screening either by clinical examination and the patients who are at risk. Okay, they should be ordered bone mineral density. Age more than 50 years or is direct indication for bone scan. Earlier to this, if there is presence of major risk factors and two other minor risk factors, or the risk assessment tool shows above the threshold, then you should do screening. Okay. So the major risk factors defined by WHO, out of this, advanced age and prior history of factor is important. The other causes for risk factors, and there are risk assessment tools. Out of which most important is WHO fracture risk assessment tool. It is a web-based tool assessment. So here you will see the various inputs such as risk factors of osteoporosis. It gives the 10-year probability of major risk factors. If this falls above the threshold, that is more than 3% of risk factors, that indicates the treatment. Thing is, it is country specific, not Indian studies, but to recommend this use for deciding treatment. Other things, that is in limited resource settings, such as a quantitative ultrasound measurement for peripheral skeleton also plays a role, especially in resource limited settings. Bone mineral density, Gold standard for bone mineral density is DEXA scan. Hip, femur, posterior and anti-lumbar spine will be measured. For lowest of these things will be taken for BMD score. Interpretation. So T-scores are standard deviations from the mean younger adults, whereas Z-scores are the standard deviations from the mean from age-matched population. Criteria for diagnosis of osteoporosis: presence of fragility factor either clinically or radiologically, or BMD T-scores less than 2.5 in a woman more than 50 years is an diagnosis of osteoporosis. Medications to prevent osteoporosis. So here comes the supplements of vitamin D, vitamin C, vitamin D supplements and calcium supplements. Other things for pharmacotherapy is menopausal hormone therapy, that is symptomatic young women less than 60 years after risk-benefit analysis it is to be considered. This patient reviewed annually, individual therapy should be given. So bisphosphonates are the first choice, drug of choice for osteoporosis and other things. Recent guidelines in 2024 says that HRT is now recommended as a first-line treatment option for younger postmenopausal women with higher risk of fractures. Sum up: nutrition, avoid bad habits such as quit smoking and then alcohol. Consult doctors for high-risk estimation, and then supplements can help in prevention of bone loss. With this, I would like to end my slide. So work towards the slogan, fit at 40, strong at 60, and independent at 80 is the aim of today's theme. So, thank you.
That was a very extensive, Sujata, that you covered so much in just 12 minutes, which is amazing. Dr. Ambuja, would you like to ask the first question? Ambuja, unmute and ask the first question.
Sujata, extensive presentation. It covered many things. My question for you is, a normal postmenopausal woman, she enters and she's likely that her bone mass is going to come down. What is it, apart from the exercise and all, what pharmacological method do you use it for prevention of osteoporosis?
Apart from pharmacological methods, depends upon the bone mineral density. If she is
normal person, she has entered into menopause. Do you want to use any pharmacological method? Because
not based on only BMD. You have to look for the clinical risk factors also. Okay. So, or not only based upon BMD, you should not treat the patient. If the BMD, if it is very less, like less than 2.5, that indicates that we can assess for the pharmacotherapy, but only BMD findings should not be taken into consideration for treatment.
No, definitely. See, the answer is bisphosphonates are the first choice to prevent osteoporosis because they don't have any loss of BMD or anything like that. Bone mineral density will be little less for any postmenopausal women. To gain that one, you need to give bisphosphonates oral and weekly once for 2 years we can give, then only there will be maintenance along with the calcium and vitamin D. Thank you.
Sujata, my question is, what is the difference between quantitative ultrasound and DEXA?
Quantitative ultrasound and DEXA. DEXA scan is more specific, and it is basically the quantitative ultrasound can use in even peripheral setup also to screen for wider area, wider population, and it also gives about the bone mineral cortical structure also in case with the quantitative ultrasound, whereas the BMD doesn't use that.
The difference is that you mentioned one of the differences, Sujata, that quantitative ultrasound, which we normally do in CAMS, the calcaneus, the heel we keep inside, that's only for peripheral. That gives you only peripheral BMD, not central BMD. Whereas DEXA, gives us both peripheral and central. The other difference is you cannot use quantitative ultrasound for finding out the response to therapy. That you can only find out from doing a DEXA again after a couple of years. Okay. And I'll have to ask you Sundari's question also. What is the best calcium salt and why?
Calcium citrate is the best salt.
We are talking about old women, menopausal women. You have two choices.
I think it is calcium citrate. I think so. I'm not sure.
Okay, you're right in that. The first one is calcium citrate. Why? What is the reason?
So it can be taken in any time of the day. It doesn't require to be taken. I don't know the answer, sorry.
Okay, I'll tell you. Calcium citrate because it does not require gastric acid for its absorption, because as we grow older, the acid secretion also comes down. That is the reason why calcium citrate is better in older women. The other calcium salt is calcium orotate. Now, orotate, 95% of it is absorbed, whereas calcium citrate, about only 40% is absorbed, calcium, okay? And orotate does not require acid. One thing, it does not require vitamin D also for its absorption. And the third advantage is it does not interfere with the absorption of iron. The only drawback is it is very expensive. Thank you, Sujata. You spoke very well, but I wish we had more time to justify the topic.
Yeah, thank you, Dr. Sujata. I think Dr. Panduranga has got his mic sorted, so maybe we'll go to him now. Ma'am, while we are waiting for him to share the slides, can I ask a question, ma'am? Can we start treatment based upon 1-day quantitative ultrasound? Because you said for monitoring treatment, we need DEXA. Would you not want DEXA even for commencing, or can we start it based upon quantitative ultrasound?
It is always better. See, quantitative ultrasound will tell you whether you have osteopenia or osteoporosis. It can tell you. But you do not start your treatment based only on BMD. You have to look at all the risk factors. Sujata also mentioned it. You have to look at all the risk factors and then take a call.
Sure. Thank you, ma'am. Yeah, Dr. Panduranga, you're okay? Yeah.
Yes, ma'am. Okay, ma'am.
Yeah, thank you.
Am I audible, ma'am? Okay.
Yeah, perfect. Please
Good evening, everyone. I thank Clinical Research Committee of the COSAGA for giving opportunity to present the management of genitourinary syndromes of menopause. So, genitourinary syndromes of menopause is a chronic progressive conditions formerly known as vulvovaginal atrophy. It is primarily caused by the declining estrogen levels during the menopause, which leads to the significant atrophy changes in the vulva, vagina, urethra, and the bladder. These changes can be profound impact on the woman's comfort and sexual functions and the overall quality of the life. It's mainly due to estrogen deficiency, the primary cause leading to the thinning, dying, and the inflammations of the genitourinary tissues. And the chronic and progressive symptoms typically worsens over the time if left untreated, affecting daily life of intimacy. And widespread impact affects an estimated of about 27 to 84% of the postmenopausal women globally, through its remains frequently undiagnosed due to an embarrassment or a lack of awareness. The decline in the estrogens impact the elasticity, vascularity, and the lubrications of these tissues, leading to the range of uncomfortable symptoms that can significantly impair the woman's quality of the life. Despite its high prevalence, many women do not seek a treatment, highlighting a critical need for increasing the awareness and open discussions. The clinical features, manifestations with a diverse array of the systems affecting the genital systems and the urinary, sexual and urinary symptoms. Mainly the genital symptoms like vaginal dryness and the blurring sensation, vaginal irritations and the itching, labial atrophy, and decreased elasticity and the thinning, and increased friability and susceptibility to a minor trauma. Sexual symptoms like dyspareunia, reduced vaginal lubrications during a sexual activity, postcoital bleeding or discomfort, loss of libido, difficulty with arousal and orgasms. That urinary symptoms like urinary urgency and the frequency, dysuria, stress and urinary incontinence, recurrent urinary tract infections. Understanding these distinct symptoms categorized in crucial for accurate diagnosis and development of an effective tailored treatment plan for each patient. So this figure shows that there is a superficial, intermediate, and the basal vaginal wall, where with the estrogens, superficial layers are more. Without the estrogens, the superficial layers are less, but intermediate and the parabasal layers are more. So coming to the management, the main management is the estrogen therapy. It is not contraindicated if the treatment of the choice for the postmenopausal women with the GSM. It's mainly given topical as well as systemic. Suggested systemic is like suggested to the patients, those who have relief from the GSM symptoms, in addition to the relief of the hot flashes and protection from the osteoporosis. But it is having some adverse effects like endometrial bleeding, breast tenderness, increased risk of the stroke, venous thromboembolism, and the breast cancers. The next is the topical. Topical estrogens also supplies the sufficient estrogens to reduce the symptoms and reverses the atopic vaginal epithelial conditions. Additional progesterone is not necessary to prevent endometrial hyperplasia or cancers. These forms decreases the vaginal pH, increases the number of the vaginal lactobacilli, improves the vagina and the urethral cytology, and that prevents the frequent UTIs. Demonstrated relief of the urinary symptoms of urgency, frequency, nocturia, and the stress or incontinence, urinary incontinences. It also resolves dyspareunia, vaginal itching, and dryness. Here are some of the preparations of this vaginal pessaries, and these are vaginal tablets, and this is the vaginal creams. So coming to the next, the selective estrogen receptor modulators, that is mainly the ospemifene was approved by the FDA. Pharmacological treatment options for the patients who are not candidate for the estrogen therapies. It is both effective and safe in treating a vulvovaginal atopy and dyspareunia by improving the vaginal structures and pH. Next is the laser therapy. This is the newer one, and the innovative treatment options for the GSM. This stimulates improved vascularity, improved the glycogen storage and collagen and extracellular matrix, producing increased thicknesses and increased thickness of the squamous epithelium. Next is the synthetic steroids, that is Dipolone. It improves the vaginal maturation index and also the increases the sex drive through the part of the androgenic properties. Next comes the oxytocin. Oxytocin gel produces a healthier and more normalizes the vaginal epithelium, but not increases the superficial cells. So here is the some of the, this is the ospemifene tablets, and this is the carbon dioxide, this is the NdOG laser, and this is carbon dioxide lasers. And next is the intravaginal dihydroepiandrosterons. This is some trials that shows that daily intravaginal applications of 0.5% of dihydroepiandrosterons superficially cells increases the superficial cell percentage and decreases the parabasal cells in the vaginal epithelium and decreases the vaginal pH and decreases sexual pain, improving your vaginal secretions and epithelial thickness. Then next is the moisturizing and lubricants. These are the temporary relief of the vaginal dryness and itching during the sexual intercourses. This is used for the milder symptoms or a conjugate with the symptoms to the topical estrogen therapies. This is a progesterone, dihydroepiandrosterone. These are all the moisturizers and the lubricants which we are using. And some of the our common phytoestrogens which will be used are these. And next is the lifestyle modifications. Sexually is the sexual to being sexually active to reduce the stress reduction therapies, psychomotor counseling, suggestions of the smoking, and wearing a loose undergarments or leg wears, avoiding irritation such as ash, soap, touches, and perfumes. And next is the pelvic floor therapies and dilators. Pelvic floor exercises can strengthen the supportive muscles and improve the blood circulations. Vaginal dilators used progressively can help maintaining a vaginal patches and elasticity, particularly in cases with a severe atopy and stenosis, restoring the comfort and facilities of intercourse. The ongoing researches like the field of the GSM management is continuously evolving. The researchers are exploring various novel minimal invasive therapies, including the stem cell therapies, platelet-rich plasma injections, and newer topical agents. These mainly the aim is to regenerate the tissues and restoring the physical functions and potentially offering a more target and effective treatment in the futures. Clinical trials are crucial for establishing their place in the standard care. So this is how the vaginal first is the without the estrogen. This is after the estrogen therapy, the layers of the superficial cells is increased. So the main, the patient, the effective management of GSM is extended beyond the prescribing the medications. It involves a holistic patient-centered approaches that respect the individual's needs, preferences, and concern, empowering a woman through the educations and shared decisions making in the paramount. The shared decision, the treatment choices should be made collaboratively and considering the symptoms, severity, patient preferences, and medical histories and the safety profiles of the different therapies. This ensures the chosen approaches aligns with the women's values and the lifestyles. Empowering educations, overcoming the stigma associated with discussing vaginal and urinary symptoms is crucial. Healthcare providers should initiate the conversations about the GSM, normalize the conditions, and educate the women on valuable treatments. Providing a clear, accessible information helps women understanding their conditions and feel confident seeking help. So these patients should be having a regular follow-up, and ongoing monitoring is essential to assess the symptoms relief, manage any side effects, and adjuvant therapies any needed. To this ensures the sustainable efficacy and the long-term comfort adapting the treatment plan as the woman's needs evolving. By fostering the environment of the offline communications and support, healthcare professions can significantly improve the diagnostic rates and treatment outcomes for the women suffering from GSM. The main conclusion is improving the quality of the health, then empowering the women through care. The genital urinary syndromes of menopause is a common chronic, often debilitating conditions that significantly impact the lives of the postmenopausal women. However, it is crucial to recognize that it is both diagnosable and highly treatable. The effective therapies ranging from the simple non-hormonal moisturizing and lubricating to the highly effective low-dose vaginal estrogens can restore the comfort, sexual functions, and urinary health. The key lies in the early recognitions, open communications with the healthcare providers, and the implementations of the tailored management plan. By addressing GSM, proactive healthcare professionals can empower women to navigate the postmenopausal phases with dignity, comfort, and significantly improves the quality of the life. Continued awareness and campaigns and professional educations are vital to ensure that no woman suffers in silence from the manageable conditions. Thank you. Thank you.
You did a very good job, Dr. Pandurangaya. Very well done. Dr. Ambuja, would you like to ask him the first question?
Yeah. Pandurangaya, you did a good job. You finished on time. And I have got 3 doubts. One, dyspareunia is one of the problems of the GSM. And most of the times when you give estrogens or any other cream, superficial dyspareunia persists. Why? And is there any treatment for that one?
And mainly dyspareunia is mainly due to one is the absence of the lubrications, and the second thing is
That's what you
because
are
of
giving already lubricants, but still it persists.
in spite of lubrication, that is the narrowing elasticity will be reduced, madam.
I'll give the answer. See, all the vagina has got the estrogen receptors, but only vulva and superficial introitus has got the testosterone receptors. That is why they don't respond to the estrogen receptors. So for that, it is either DHEA is a better option or testosterone gel, though it is not approved in India, that can be done, or it can be the oral medication also is good, that is the Tibolon. That also gives, because it is both estrogenic, progesterogenic, and testosterone. That is why these 3 things can be used. My second question is, what is your opinion of using the probiotics for GSM?
Probiotics nowadays it is increasing, madam. People are using it, will increases the flora. By increasing the flora, we can increases the pH and reducing the pH, madam, and it will increases the moisture content of the vagina, madam.
Shall I ask one more question, Jyotika? Because you mentioned about the ospemifene. I do agree with you. Where estrogens are contraindicated, you will go for ospemifene. Is there any other advantage of ospemifene? One is non-hormonal method. Any other advantage? It is a oral medication.
Yes, ma'am.
Oral medication. Maybe people they don't like their vulva vagina to be touched. So this is the one, that's the advantage. Okay, good. Jatika, you can carry on.
Ask her. Now, just Dr. Pandurangaya, one 75-year-old woman walks into your clinic with severe GSM. How will you treat her?
Ma'am, any patient who comes with the GSM, we have to see what are the complaints she is having, and mainly if she is having only the urinary symptoms, means we have to strengthen the by mainly we have to give exercises and increase the moisture content, and we are other than the estrogen therapy is the best, madam. But we for 75 years patients, they are very poorly responding for the estrogens, madam.
I want
So,
to no, Pandurangaya. It is not like that. See, why I mentioned the age was that normally when we are talking of menopausal hormone therapy, we say within 60 years or within 10 years of attaining menopause. But
menopause.
GSM is the only exception where you can give local estrogen. Okay, you can give local estrogen without any contraindication. Okay, regardless of the age. Please remember that. So, no, your last line was no woman should be allowed to suffer, right? So,
Yes, ma'am.
same thing holds good here. Well, Dr. Sundari has one question. I'll just tell you. Now, what is the contraindication for local hormone therapy in women with GSM? Actually, it's a relative contraindication. Okay, tell me.
The
Well,
patients with estrogen therapy will having pruritus.
No. See, breast cancer survivors. Breast cancer
Breast cancer,
survivors be either on tamoxifen or
amoxicillin,
be on no, aromatase inhibitor.
aromatase.
Okay. Now, those who are on tamoxifen, you can give them local estrogen without any problem. But those who are on aromatase inhibitors, you have to have a shared decision between the patient, the gynecologist, and the oncologist because you're going to have problems even with local estrogen. Okay. So that is the only relative contraindication because once you talk to all of them and they say, okay, it has to be done, there is no other go. So you keep monitoring her and you give the local estrogen. Okay. And one more thing is how long can you wait? What do local estrogen studies say about endometrial safety? How long? As of now?
24 months, 24 months, man.
Very good, very good. So there are studies only up to 2 years. We do not have studies beyond 2 years, so we need to be careful. Okay. Thank you. Thank you, Pandurangaya.
There is a question in the chat box actually following what you have asked only, ma'am. So
Yeah.
how long, if you're giving it for prolonged period, does it need progesterone? So is the question. So up to 2 years, we can safely give without progesterone.
Yes, absolutely.
Ma'am, is there a difference, no, ma'am? Estrone, estriol, and estradiol in the vaginal one.
Yes.
So is there any difference in terms of which we prefer and in terms of the endometrial safety as well and the length of therapy?
Yes, there is. Ambuja,
Yes.
next question.
I didn't listen.
See, which is amongst estriol, estrone, and estradiol, which is more potent for
Yeah, estradiol is more potent.
yes.
That is why the vaginal creams are all estriols, which is less potent and will not have much effect on the endometrium. And unless there is a postmenopausal bleeding, there is no need of surveillance, endometrial surveillance when you give the vaginal estrogens. And about your cancer breast, estriol cream can be used if it is a
No, you can.
ER negative things without any problem, and it can be used as many years as possible, and as long as there is no postmenopausal bleeding. Only you should be more careful when they are on tamoxifen. Do surveillance every year for the breast cancer survivors.
See, the thing is, when they are on vaginal estrogens, normally we do not do the endometrial
Yeah,
surveillance.
normally not, only breast cancer
But
survivors.
there are some reports which say that there have been reports of endometrial hyperplasia and an occasional endometrial cancer, even with vaginal estrogen. So I think the bottom line is not that you don't bother, you still have to bother and be careful. That's it.
Sure. Thank you, ma'am.
Yeah, all the three have presented very well. Congratulations.
Thank you, ma'am. Thank you very much. And I think
Shall
this
I
was
share
one
the
of
screen
the,
now?
yes, ma'am.
Yeah, I think if you
It's a
go
great
back, then I
pleasure
can.
to have our expert, Dr. Ambuja ma'am, whom we have already introduced. It's a great pleasure to hear from you, ma'am, the past president of IMS. So we are going to be discussing about, ma'am is going to be speaking to us on the current recommendations of menopausal hormonal therapy. Thank you, ma'am.
Yeah.
I'm pleased to say this is one of the best attended webinars, ma'am. Jyotika ma'am.
Yeah. How do I share my screen?
Nietzsche, you have the share button, no, ma'am. Click
Yes.
on that. And then if you go to the screen,
Yeah.
if you've opened your PPT, you can then click on your PPT, ma'am.
Yeah, this is open, but I think you should go back. Then only I can see.
No, ma'am, you can see the share is already allowed, ma'am. Share screening is allowed, ma'am.
Do share
Choose to
screen.
share app Zoom window, entire screen, is it?
Ma'am, no, share entire screen, ma'am. And then
Yeah.
you go and open your, you go to that PPT screen, ma'am.
Yeah, my screen. Are you able to see now?
No.
Oh, nothing, not yet.
No, ma'am, no, ma'am. So you click on the, I mean, you open your PPT, no, ma'am. You click on the share one. And when you click on the share, the first screen which comes, if you click on that.
Entire screen. Yes, I have clicked.
And then, go to your PPT, ma'am. Yes, ma'am, it's coming now.
Is it coming?
Yes, ma'am, it's just coming.
Are you
Yeah,
able
now
to
you
see?
open your PPT, ma'am. Yeah, you click on that PPT, ma'am.
Are you able to see now?
No, ma'am, you open that PPT. Click on that PPT. Yes, ma'am. Now you put it as a slideshow, ma'am.
Are you able to see my thing?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Perfect, ma'am.
Current recommendations of MHT?
Yes, ma'am.
Perfect.
Yeah. Thank you, Kasoga, Dr. Jyotika, and President, everybody, for giving me the opportunity to speak about current recommendations of MHT. The aim of today's discussion is to provide evidence-based information about MHT, address the controversies, practical advices. Are you able to hear me?
Yes, yes.
Yes, ma'am.
Yeah.
Yes, ma'am.
And best practice healthcare. With this, women can empower to make personalized choices. Menopause is the key factor contributing to non communicable diseases in women, including cardiovascular, bone, and cognitive health. So, the 5 W's should be answered, that is, to whom, when, where, how, all these 5 problems I am going to answer. And more than anything, quality of life is important, and nobody should suffer with the problems in the peri or postmenopausal. Many of the things
Ambuja,
which
your
in
slides
our
are moving.
yeah,
Ambuja, slides are not moving.
no, I am not moving.
Okay.
Still. And many distressing symptoms are present which need to be tackled. But unfortunately, all the pharmacological or non-pharmacological methods are available for only postmenopausal women. They are not addressing the perimenopausal where the symptoms are more. So that has to be observed, to be tackled now. And second is about the contraception in the perimenopausal women, what to give and what not to give. Menopause healthcare systems and treatments that are more symptom focused rather than stage focused can better meet women's needs. Always, you don't say that she's postmenopausal only, I will treat, otherwise, I will not treat. It is the wherever the symptoms are present, we have to treat. Better still is a life course approach, means the prevention is better than cure. We need to take care of all the things from the beginning. All of us know, as I said, it is the thing, though menopause occurs about 4 to 5 years before the menopause itself, all the symptoms will start. And we have so many RCTs that are being done because the hormones are there since about 50, 60 years. But what is the end result of it is, once this WHO study is released, where 90 million prescriptions before were present, drastically 32% has this, because of the fear of cardiovascular disease and breast cancer. Now we'll analyze what is the impact of it and how it can be changed. The present situation is only about 4.7% of women are using the hormones in America. Of course, in India, we don't have a good statistics. And what happened to the 15 years of post WHO study? The big concern in clinical practice is not the overuse of hormone therapy for prevention of chronic conditions. It is the underutilization and under-treatment of women who deserve the treatment they are not receiving. So, how can we increase the acceptance, and how can we decrease unwanted effects of MHT by appropriate selection of MHT? Now, regarding this, both healthcare providers and the patients are equally confused. So, what are the current recommendations that are there? One, MHT is not for all postmenopausal, it is only for symptomatic. And what are the symptoms that needs a thing? Vasomotor symptoms, grade A recommendation means it should be given. For POI and early menopause, again grade A. Genitourinary syndrome, just now our Panduragaya has searched GSM, the grade A recommendation. Prevention of osteoporosis and fractures in high risk women. Not for all osteoporosis patients, high risk women, if it is present, yes, it is accepted. And one more thing which we should give importance is the recurrent urinary tract infection after ruling out other causes, and where there is no infection, it is because of the estrogen deficiency. So that also needs to be tackled. MHT started within 10 years of menopause, that is below 60 years of age, is very safe, and up to 10 years of menopause. Not for primary prevention of diabetes, metabolic syndrome, and Alzheimer's. I think I made it very clear. These are the recommendations as on today. And added recommendations are shared decision making and personalized treatment plans is necessary. Why WHO is failed is it is not a personalized and one dose and one method used for everybody. That is why there is a failure rate. And extended hormone therapy if no contraindications. This is again very important because many people, they get heart pressures like me. Even at this stage of 70 years, I got the heart pressures. Can we use hormones? Yes. If there is no contraindication, we can use. In women older than 60 or 65, hormone therapy does not need to be routinely discontinued. It can be considered for continuation beyond age 65 after appropriate evaluation and benefits risk counseling for persistent VMS, quality of life issues, or osteoporosis prevention. So this is a new add-on that has come in the recent one as the 2022 from the International Menopause Society. For GSM, vaginal estrogens and systemic estrogens, if required, or other non-estrogen therapies may be used at any age for extended duration if needed. Risk stratification should be done before starting MHD. This is what is the personalized management, that is where it should be insisted. And Comoglobin initiative, that is core outcome of menopause management, and should be followed. I think I made it clear. This is very important. Not for everybody we are giving. In unexplained vaginal bleeding, stroke, and MI, VTE, breast and endometrial cancer, active liver disease, it is better to avoid. In healthy women, we need to give for menopausal symptoms, but always we forget what are the associated symptoms that will come because of the estrogen deficiency. We, all of us in our clinics, we get patients who always complain when muscle aches, when short muscles and joint pains, all these things. We don't give much importance for that one, but they are all because of the estrogen deficiency, like disrupted sleep and muscle and joint aches, especially in Asian women, and new onset mood and cognitive symptoms many a times, and fatigue, palpitation, changes in body habitus, and sexual dysfunction. Very important. And one more thing we should give importance is why we should treat vasomotor symptoms. Many times in Indian women, many of our people tell, oh, what is their menopause? We get vasomotor symptoms. There is no need to treat. No, no, no. Vasomotor symptoms are the pre-runners of the cardiovascular disease. If more of vasomotor symptoms, they are more prone for hypertension and cardiac events. You should remember. And bone health is 20 to 30% of the reduced risk of hip, vertebral, and total fractures. Just now we heard how dangerous it is. And there is some attenuation of protection following cessation of MHT. However, importantly, there is no evidence of increased risk of rebound fractures on discontinuation of hormone therapy. So we can give very safely. Cardiovascular health, how much we are justified in giving the patients. Best is to give that, I'll tell you how to risk stratification to be done later. After doing the risk stratification, it should be given as a protective for POA, not for a normal person who has got a menopause normal events. So this is what is the difference between HRT and MHT. If you give it for the POI, that is premature ovarian insufficiency or early menopause, we are replacing the hormones that have gone. That is what is the HRT. But for the menopause, it is the menopause hormone therapy. Individualization of the treatment is necessary, where in the case of the cardiovascular, it is a transdermal estrogen and micronized progesterone, and LNG-IUS do not appear to increase the VTE risk. And transdermal estrogen and micronized progesterone appear favorable to blood pressure in normotensives, means about the LDL cholesterol and HDL cholesterol, which are favorable. Women with neutral to blood pressure in hypertensive, either hypertensive or it is a normotensive women with cardiovascular disease, we can go ahead with the transdermal estrogen and micronized progesterone. Oral estrogen appears neutral to blood pressure in hypertensive women. It can also be given. And this is what is very important. Type and dose of hormone depends upon the uterus present or not, contraceptive needs there or not, symptom and type severity, and comorbidities. I just now I told you, perimenopausal women suffer more, so we need to give attention to them. Now, what are the preferred preparation? Forget about all the past. I'm not going into the ethinyl estradiol or Primarin. They're all away. We don't use it at all. Now, what we use is the 17 beta estradiol over other estrogens, because it is a biologically identical hormone. Why that is any other hormone? It has got effect on the liver. That is why stays for a long time.
ವಾಯ್ಸ್ ಕೇಳಿಸ್ತಿಲ್ಲ ಮ್ಯಾಮ್, ವಿಡಿಯೋ ಪ್ಲೇ ಆಗ್ತಿದೆ.
You are not able to hear me? Hello?
No, ma'am, sorry. Arun, mute others. No, ma'am, we can hear you, ma'am. Please carry on.
Rapidly available after ingestion, leading to minimal liver load. That is why what is the best estrogen we have to use? It is the 17 beta estradiol. It has got preparations: oral, transdermal, spray, gel, patch, and vaginal. What about the progesterones? Forget about medroxyprogesterone estate, which has become hero to zero. No, we don't consider at all now. Only two estrogens, that is the natural micronized progesterone and dydrogesterone. When these two things are to be used. And SERMs, it is not approved, but Tibolon, yes, which is estrogenic, progesterogenic, and androgenic. And in case if you don't want to use, bezodoxepine plus CEA combination is indicated. Ospemifene, DHEA, testosterone. This is another new entry, that is estradiol under third phase trial. You should remember, because this is from the fetal liver estradiol. It comes. It is a very good, and contraindications are less, side effects are less, and if it comes out, it is going to be a miracle. Every time something or other, when estradiol came, we thought it is a pinnacle, but now the another entity, that is the estradiol E4, it has come. So some of the indications I told you, always we prefer oral, but non-oral indications like gallbladder disease, obesity, smoking, previous venous thromboembolism, varicose veins, all after seeing for the risk assessment only. So again, coming to the dose, one dose doesn't fit, and always start with a lower dose, transdermal 0.025 milligrams, oral zero point 0.5. And if symptoms are not relieved in 4 weeks, increase the dose. And if there is a breast tenderness or anything, reduce the dose. Stop if VTE or stroke is present. Lowest available transdermal dose is 0.14 milligrams for bone loss. And estradiol patch also is available, not in India. This is a new transdermal, the MDTV technology. It has come. It still we are not using this because though it is good and it is costly. What about the oral versus TD? Transdermal bypasses the liver, and where it is the triglycerides is more, transdermal is the best, and it is a transdermal is lipid friendly. That is why it can be for endometrial protection, and we suggest against quarterly progestin regimes are probably not adequate to use the thing. And what about micronized progesterone and dydrogesterone? Yes, micronized progesterone is good in America. They use it, but dydrogesterone in other countries they prefer. Adaptive hyperplasia and cancer can occur after as little as 6 months of unopposed estrogen therapy. During the menopause hormone therapy, the use of progesterone is only to protect the endometrium. Very good. If they don't have the uterus, only estrogens can be given. Otherwise, progesterone has got no role when medroxyprogesterone was used, which is more harmful than the estrogens. But now, these two are the patient friendly. I mean, this micronized progesterone is metabolically neutral. What does it mean? It does not negate the beneficial effects of estrogen on lipids and does not appear to increase the risk of either breast cancer or cardiovascular disease, although data are limited, because except for the WHO study, until now there is no better study where RCT, that is randomized control trials, are done. Until then, it proves though we used bad hormones like primarin and medroxyprogesterone, it is a referral for us. The usual dose of micronized progesterone is 200 milligrams for cyclical use and 100 milligrams for continuous use. If below that, if it is there, it cannot give endometrial protection. Again, I want to repeat, the progesterone used in MHT is only endometrial protection to prevent endometrial hyperplasia and endometrial cancer. And what about dydroprogesterone is better absorbed orally than medroxyprogesterone. We have 2.5 milligrams, 5 milligrams, 10 and 20 milligrams also available. What makes dydrogesterone a unique molecule? Dydrogesterone is highly selective for progesterone receptors, thereby decreasing the risk of adverse effects. It has got no estrogenic, androgenic, or no glucocorticoid effect, so it can be used effectively. Esther study has conducted to see the effect of all the hormones on lipid profile, and micronized progesterone it favors MHT, and oral estrogens favors placebo. That is why micronized progesterones can be used, dydrogesterone can be used for MHT. What about the choice of progesterone in breast cancer patients? That's what is the question. Baseline risk without using any hormones, if you take it as 1, and estradiol and dydrogesterone is very minimal, that is 1.13, whereas synthetic progesterones, it is used, it has gone to a very high level. That is why the cancer breast that is blamed for the MHT is very minimal if you use the progesterones. Actually, if you analyze the WHO study, all the problems are because of the progesterone only, not with the estrogen. One thing. Second is because that synthetic progesterone is used, that is why the problems are more. With the natural progesterones, the problems are very much limited. What to consider while making right choice? I told you whether the uterus is present or not. This is a very major thing. When uterus is present, you have to give estrogen, progesterone, or otherwise it is only the estrogen that has to be given. What are the methods of giving? I already told you, in perimenopausal women, people suffer with vasomotor symptoms and joint pains, aches, and everything. So we need to address them. That is why the combination of estradiol and dydrogesterone can be given sequentially for perimenopausal women and premature ovarian insufficiency. What do you mean by sequential? First 14 days only 17 beta estradiol, and next 14 days it is the both estrogen and progesterone. Mind, madam, whenever we are giving progesterones for endometrial protection, no haphazard means half-hearted giving. Don't give it for 1 week or 10 days. Many people will give last 1 week or 7 days treatment, 10 days treatment. No, we need to give 14 days regime if you want a good endometrial protection. That is also a full dose. That is, if you give microprogesterone, it is 200 milligrams, or if you give dydroprogesterone, it is 10 milligrams. And duration of treatment till natural age of menopause in the perimenopause and POI. What about postmenopausal patient? Again, if hysterectomy is done, only estrogens. If hysterectomy is not done, it is a continuous combined menopause hormone therapy, means you will not give any gap. The 1 milligrams of estradiol and 5 milligrams of dydrogesterone. And we should inform them that 90% of the people bleeding will not occur, but within 12 months a breakthrough bleeding may be present because endogenous hormones can be present for 1 year, that is 12 months of the menopause. And we are talking about the digesterone and E2 preparations only, that is the oral one. Otherwise, we don't have right now micronestrone and estradiol combination. Very clear now, no other preparation other than estradiol is used only for vaginal. It is the estriol preparation is there, and estritriol, that is E4, is going to come. It is in the phase 3 trial. What about right now? There is estradiol and natural micronestrone oral preparation is going to come. A new menopausal hormone therapy preparation containing estradiol combined with micronestrone is now available in Australia. Oral preparation is indicated for use during continuous combined hormone replacement therapy for estrogen deficiency symptoms in menopausal women with an intact uterus and with at least 12 months since the last menopause. This is the latest one that is there. And perimenopausal, yes.
Ma'am, 20 minutes are up, ma'am. So
yeah, I will try to wind up. Give me 5 minutes.
Sure, thank you.
And can we use cirrhosis in perimenopause? That's the question always we have. Perimenopause. Usually we don't use except for giving the. You can use LNG and add back estradiol can be used. And tibolone, yes, it is a very good drug. Only thing is we can use it only 12 months after the period. It cannot be used in the perimenopause. And CEA and bezodoxepine combination also is good. I already explained you this. This is what is very important. How do you start? How many years you can give? Recommended duration is 3 to 5 years due to breast cancer risk. And estrogen only can extend up to 7 years with lower breast cancer risk. Is a for first 3 months every month follow up, then 3 months, 6 months is very very important. Every time you do follow up, complete checkup is very important. And stopping the treatment, no clear whether you are going to taper or abruptly stop, but once withdrawal is done and again if the symptoms occur, we can do it again. This is very important. Whenever you give hormones, what is that as a physician I am going to do? Means decide whether it is symptomatic or asymptomatic. For everybody, do complete checkup, and preventive health care is important. I need not mention about the preventive health care, what is the complete checkup, and everybody, risk stratification for this is important. Risk stratification is for the non patient who is a normal one, not diagnosed as of having any diseases. And this is what is important after doing risk shared decision making and individualization, and alternative options if the estrogen is not. This is what is the risk stratification. These are all the things what we do, like breast, CVD, and sarcopenia. All these things we are going to do. The risk every way thing that's available. Example, I am telling CVD. We will take triglycerides, age, whether she is diabetic or not, and how it is going to help. After risk stratification, we will decide whether she is a low risk, moderate risk, or high risk. If it is a low risk, safe, we can give. Moderate risk, transdermal. High risk patient, don't give any MHT. And timing hypothesis, I already told you, below 50 years, 10 years of menopause, it is safe to give it. In comorbidities, are we going to go? Always we have the doubt. What about hypertension, whether to give it or not? Diabetes, give it or not? Yes, you can give it very safely, because diabetes, MHT reduces the fasting blood sugar. HbA1c is reduced, total cholesterol is reduced. Only worry with the diabetes is increases the cardiovascular disease. Because of all these things, it is very good, we can use it. Renal failure, heart failure, rheumatoid arthritis, thyroid, all these things, Parkinson's, they are not contraindications. Migraine only, where if, see, it is a estrogen dependent, is it not? So don't give sequential regime. If the patient comes with if she had a history of migraine, give them continuous regime, that will be good. And cancer survivors, we avoid in uterine sarcoma, low grade ovarian serous tumor, clear cell, sex steroid. Otherwise, we can use it only in the breast cancer survivors. ER positive, avoid. ER negative, use with caution. Use alternatives if it is there. And stop treatment if migraine appears for the first time, headache gets worsened, blurring of vision, jaundice appears. And follow up, I already told you how to use. And tips, I insisted so many times, I think I need not repeat. To conclude, being menopause women is not an indication for MHT, only for targeted population. Individualization is very important. Like all medicines, HT needs to be used judiciously, but it is essential that women in early menopause who are suffering menopausal symptoms should have the option of using HT. And informed choice is very important. I think I made little clear, and thanks again for giving me the opportunity to deal with the subject. Thank you very much.
Thank you very much, ma'am. Thank you, ma'am. Sir, Jyotika, ma'am.
Yeah, thank you, Ambuja. That was excellent.
Thank you, Jyotika.
Very good. I don't think anybody has any doubts regarding the current management of MHT, current recommendations of MHT. But just to put it in a very short nutshell, I would say that we have to consider the NAMS, that is the North American Society's position statement, which was released in 2022. That is what we take now as the Bible, the latest Bible for MHT. And there are just 5 or 6 points which we need to remember. Earlier we said within 10 years of menopause and not after 60 years. But now, if the patient was taking MHT before 60 years and now she's reached 60 years, should she stop? With shared decision making, she need not stop, but she can continue it, of course, under surveillance. The second thing is, as it was in the past, we still do not prescribe MHT for prophylaxis of cardiovascular diseases, osteoporosis, or Alzheimer's. Then again, if a patient comes with GSM at any age, that's why I asked that question to Dr. Padurangaya. Any age, if the patient comes with GSM, there's no contraindication for local estrogen therapy. Then again, earlier we had conjugated equine estrogen and medroxyprogesterone acetate, but now the current menopausal hormonal therapy do not have both. We have, like how Ambuja has shown it very clearly, we have 17-beta estradiol, a natural estrogen, which has very minimal side effects either on the lipid profile or on coagulation. And we have the dydrogesterone. Abbott has come out with the preparation of 17-beta estradiol and dydrogesterone, and we heard from Dr. Ambuja that in Australia they have come out with 17-beta with the micronized progesterone, which is very good. So, girls, well, no, not girls, everybody, I would say, be confident of prescribing MHT. The only drawback is the cost. It comes to about 1,000 to 1,500 rupees per month, which may not be affordable for most of our middle class women. But till then, we can definitely prescribe them isoflavones, which as of now do not have any major side effects. Thank you so much.
Hello. Good evening, everyone.
Hi,
Good
Shobha.
evening.
Good evening.
Hi. Ambuja madam, great talk. Great talk.
Thank you.
Very nice. Very well brought out all the latest guidelines and a very correct timing for Kasoga to bring this forward, and very well done, Srimati. And of course, Jyotika also for bringing all these topics. All speakers were good. I just wanted to say here that today the perspective has changed for MHT and the latest guidelines also. And also let the practitioners believe firmly that MHT does have prevention for atherosclerosis, does have prevention for osteoporosis, if started at the right time. The time of initiation is of critical value. So it should be started at the right time, and sometimes that may be even earlier than the final menstrual period. That is why there is a huge concept about the window of opportunity which we do get in the perimenopausal period. And that is when we encourage women to consult us early for their symptoms. I think correctly started at the time that estrogen deficiency starts showing up. It does have some role in primary prevention of cardiovascular disease. Of course, in secondary prevention, it does not have any role. It can cause potential harm. And also in prevention of osteoporosis. Another thing is in women who are being treated for osteoporosis, but at the same time they have vasomotor symptoms, I think they will benefit with MHT, and in turn that will also kind of help in managing the osteoporosis also. In addition to the anti-osteoporotic management, so the multidisciplinary approach will have to come in here. All the treatment for other disorders will come, especially osteoporosis, management by the orthopedicians, rheumatologists, etc., physiotherapists, etc. But from the gynecologist, if MHT is needed as in symptomatic women, and it's great that the age has been extended. I still remember Dr. Bairam Anklesaria, who is one of the founders of Indian Menopause Society, and he said that if a woman is doing well on MHT and has no additional risk factors, please continue the MHT, don't deny her that. So I think it depends on the woman. So that was very nice. I am really happy that I joined today. And I congratulate all the speakers and the organizers.
Ma'am, there is one question in the box, ma'am. I think as a case of post BSO and a 35-year-old uterus intact, how to give HRT. I think Dr. Uma Alluri has been asking this.
Yeah, I know. She wanted to talk. Maybe I can, if you can give me the number.
Yeah, I think she can unmute and speak.
Yeah.
Timing is very important, Shobha. Dr. Dukladas is very
You can do the results then, and she can do the this thing question in the chat box.
Yeah, she's put the question, ma'am. Yeah.
No, if you can give me your number, I'll talk to you and explain to you. Okay.
What's the question? Can you repeat?
Yeah, I think the question should be discussed here if possible, because it's a webinar.
The case of post BSO, ma'am, 35-year-old uterus intact, how to give HRT?
MHT.
Why was the uterus retained?
Yes, ma'am.
Yeah,
Ma'am, that's the
you can
question.
very safely give estrogens plus progesterones.
First of
Because there are conditions where the prophylactic measure only bilateral oophorectomy will be done and uterus will be intact. In such cases, you have to give both estrogens and progesterones combined. That is what is necessary. As all of you know that it is the estradiol and dihydrogesterone combination. You can give continuously or because if she's only 35 years, you can give sequential regime where every month she will have the bleeding. Either continuous or you can use only 14 days regime, whatever it is. 28 days you give and give a period that to have the withdrawal bleeding so that she'll feel that she'll have the menstruation at the same time. It is preventive for osteoporosis, cardiovascular risk, for everything.
Thank you.
I think the greatest indication for MHT is in surgical menopause and in premature ovarian insufficiency. Where we call
until
it
the age of
HRT, but
the
it's till the age of natural menopause.
natural
it can be given.
menopause.
Yes, yes. So I don't think there should be an hesitation, but one has to develop the nuancing of the prescription and risk factors one has to identify. Yeah.
So another question somebody has asked, can we give OC pills? I put the question there, you can see, because all our traditional OC pills have got the ethinyl estradiol, which is 100 times more potent than the estradiol, which is causing liver load. That is why we are not giving ethinyl estradiol in the postmenopausal or perimenopausal women. We can change to estradiol tablets and we can use microspostone or dydrogesterone, or you can LNG IUS also can be used, which is a local one. But estradiol is a preferred drug than the ethinyl estradiol, which has got in the all our COCs. That is the traditional COCs that is there.
Yeah, I think Udayshree's question stems from the fact that many books still recommend low dose COCs in perimenopausal women for the window of opportunity when contraception is also the requirement. It is actually category 2 in such cases if they are non-hypertensive and no cardiovascular illness. So there is some role, but it requires too much of care and precaution. I think Srimati, please continue with Srimati.
Sure.
So
ma'am.
one more thing I want to tell Shobha.
Yes.
Any COC below 35 years, if she is non-smoker, non-obese, that is the COC containing ethinyl estradiol is good. Once they cross 35 years,
Madam, it is bound to be safe in perimenopausal also, but with a lot of careful, we need to take a lot of care in ruling out cardiovascular risk factors. Madam, I think let them proceed with the rest of the assessment and everything.
Okay.
They have a lot of work.
The webinar is over, ma'am.
No. What about your judgment and all?
No, ma'am, that results will be announced only later, ma'am, not today, ma'am.
Fine. You take it over. Okay.
Yeah. So thank you very much, ma'am. Sir, can we end the webinar? A vote of thanks and end. Any remarks, sir?
Is Dr. Shobha Bembalgi there? Can't see her.
No, ma'am.
Then you
Sorry, sir is also not there. Ma'am, anything you want to say, or shall we say the vote of thanks and then conclude?
Yeah, you can say it. Go ahead.
Thank you, ma'am.
Yeah.
So thank you everybody for joining in for this webinar series. I thank our expert Ambuja ma'am who's taken out the time to be with us for being a judge as well as an expert. I thank our judges, Dr. Jyotika ma'am and Sundari ma'am, and of course Jyotika ma'am for being behind me at every step. Thank Sir Durgadar sir for this opportunity, for this initiative. Thank Shobha ma'am for all her support, and Shobha Bembalgi ma'am for her support. I thank all the delegates who have joined in for the webinar. Thank the 3 speakers from the 3 societies who have done an excellent talk. So please stay tuned for our webinar series, which happens every second Tuesday, and the next one is going to be in October. It's going to be the 12th of October, the same time. Sorry, the 14th of October. We meet again at the same time, 5 o'clock, and the theme is going to be cancer. So with that, I'd conclude. Anything, ma'am? Jyotika, ma'am?
I think that is it. And thanks, Ambuja. Thanks again for joining at short notice. We just gave you 1 week, but you were so sweet. Thank you so much.
Thank you.
And thank you,
How
Arun,
to
for all
send
the
this
work.
paper?
No, she is in America, and for some reason she's not able to join.
Yes, ma'am.
Last time also the same thing happened, but I think by 14th October, hopefully Sundari should be here.
Assessment papers, how to send?
Ma'am, you can send it as a photo to ma'am.
Okay. To Jyotika?
Yes,
Yeah.
ma'am. Yes,
Yeah.
ma'am.
Done.
Yeah.
Thank you.
Thank you, Arun, for all your help, and thanks to all the participants who have joined in overwhelming response despite the last minute issues with the password. So thank you very much.
Yeah, thank you, Srimati, for all the efforts.